Welcome to this satellite symposium presented by NephroSant, QSant, a window into kidney allograft health, early experience in adult and pediatric patients. The speakers for this session are Matthew Cooper, MedStar Georgetown Transplant Institute, Alex Weissman, Centura Health, Porter Adventist Hospital, and Millie Samaniego, Henry Ford Health System. Dr. Weissman will also be serving as moderator for today's session. Please stay tuned after the session talks for the panel discussion. If you would like to submit a question directly to the session moderator, please utilize the Q&A feature on the side panel of your screen. Enjoy the session.
So hello, everyone. I want to thank you for attending this symposium. This is sponsored by NephroSant. We hope this is a time that's well spent. This is a window into kidney allograft health. This is, again, an effort to try and give the audience additional opportunities to improve the outcomes for our kidney transplant patients. As introduced, I'm Dr. Matt Cooper. I'm going to talk about experience with current biomarkers, some of the pros and the cons. Follow with Dr. Alex Weissman, who's going to talk about novel approaches to kidney health assessment, introducing you to things called the QSant and the Q-score. And then Dr. Millie Samaniego is going to give us some clinical applications of QSant, which is a multi-analyte urinary biomarker for kidney transplantation. Again, we really hope this and wish we were in person. But again, at the end, we do have some question and answer time for folks in the audience to be able to participate in this conversation. And again, we think this is time that's going to be very well spent, and hope you'll find at the end some opportunities to introduce additional biomarkers into your post-transplant management for your kidney transplant recipients. So I'm going to start things off. I had the opportunity to talk about sort of the current landscape and where we are today. And again, hopefully this is something with which many folks on this call today have experience already. But I'm going to try and sort of bring things together, highlight some of the major publications that really have guided us over the last 5 years. Importantly, throughout this pandemic, I think have proven themselves very valuable. And so I'll start with my disclosures. I do have, I'm part of an advisory board for CareDx, Natera, and Transplant Genomics. And again, that hopefully indicates that I have a profound interest in this particular topic as a transplant surgeon, and also as my role in the OPT, and I'm particularly interested in long-term outcomes. Our first slide is going to, again, I think, demonstrate, which hopefully is a little bit provocative and maybe gets people to a place where we can really start to wrap our heads around the challenges as to why we don't see tremendous improvements over our outcomes, both in deceased donors and living donors. Now, we're still excited about the fact that we have successes in transplantation, but it seems if we focus perhaps too much of our attention on very short-term outcomes and aren't in fact maybe appreciating the fact that we have yet to come to a place where we can truly say that we are allowing for one organ for one patient in one lifetime. And if you look at this data, which again is published in the OPTN's annual report, you can see that really the survival, the 10-year survival, really hasn't changed much. And we've had some significant advancements in immunosuppression, which have, again, improved those curves somewhat, particularly the decade that's probably off the slide. But I'm going to challenge you to think, is there a way in which we should look at this in a much longer time frame so that we can, again, potentially reduce the numbers of folks on the wait list and reduce the numbers that are returning to that wait list. In terms of following patients post-transplant, I think we're all in agreement the fact that the current techniques and the current data and the current opportunities that we have available to us really do not meet the mark in 2022. Our current standards of utilizing serum creatinine, which we teach our med students is really a gross tool, is really as an insensitive marker, and it's really poor in its ability to prognosticate future events. It delays quite significantly any evidence of injury to our organs of interest here, that being the kidney. All the way to the right, I think many of us utilize donor-specific antibody on a regular basis, and that, of course, is used in the diagnosis of acute antibody-mediated rejection, but not really utilized in T-cell mediated rejection. It is very valuable in an early marker of immune response. And again, as I say, I think really all of us are now utilizing it clinically in the post-transplant management of all our patients, particularly despite our efforts to try and delineate high and low risk patients, the truth is that in the face of potential non-compliance, everybody potentially can become a high-risk recipient. And so donor-specific antibodies become very valuable. Biopsy, which is, I think, still seen as the gold standard, I certainly believe it to be, for diagnosis of acute rejection, itself is imperfect in terms of sampling errors. It does have limited utility in that it does require a needle into a kidney, which has some potentially complications associated with it. I'm always saying that if you haven't seen complications associated with the biopsies, you probably haven't done enough of them. But it is in some ways late to the table if in fact we are not identifying potentially an earlier prognostic marker that in fact there is some injury related to potentially rejection. And so again, we have this in front of us, and I think we've all come to the appreciation that we have to think that there potentially is something that we could use that will allow us to be sort of more on the front end. And now biomarkers have become really I think a very popular utilized technique in our post-transplant clinic. The utility is in predicting future events, not only rejection, because I think we've become confident in saying utilizing things like cell-free DNA are markers of injury, and we also use them potentially as indications of infection and potentially utilizing in efforts to avoid graft loss. It can help us guide our management after an event, particularly in rejection, as many of us, even after utilization of some powerful medications to treat rejection, we still are uncertain of the success of that. It can provide additional information in helping us to guide management and even our stable patients, as many of us see the opportunity now to think about utilizing them in minimizing immunosuppression and the side effects associated with that. And of course, what is sort of front and center is the ability to use these biomarkers to help identify rejections in a less invasive manner, i.e. avoiding biopsies. This is the initial data, which gathered, again, appropriately lots of excitement, lots of enthusiasm, known as the DART study. And you can see in this, published by Dr. Roy Bloom and others in the Journal of American Society of Nephrology. Hard to believe that was way back in 2017. And if you look at this data, again, it began to demonstrate on the left panel that utilizing that marker of 1% fraction of deceased donor cell-free DNA, there was, again, an ability to what was thought to identify, again, in an earlier for-cause biopsy group, demonstrations of potential antibody-mediated and cellular-mediated rejection. But the negative predictive value and positive predictive value, as you can see on the slide, 84% and 61%, albeit good, were still felt to be imperfect. And when really looking to differentiate one versus the other, we quickly came to recognize that at that fraction of 1%, that utilizing cell-free DNA was particularly more valuable in diagnosing antibody-mediated rejection compared to cellular rejection. And that is really, I think, further defined on that right group of bars. Again, looking at the no evidence of acute rejection, the first bar, all the way over to degrees of 1A and 2A cellular-mediated rejection. The differentiation really seemed to drop off when we compared one versus the other. And so, again, there was some obviously interest in this, but still felt that it was an imperfect test, and we needed to gather more data. And that's, again, where we had more and more of these registry studies. That data that was shown on the previous slide was reaffirmed in a publication in AJT in 2019. Again, which showed the fact that we were really able to differentiate with the use of cell-free DNA at a 1% level, that utilizing was really better able to identify antibody-mediated rejection in matched biopsy samples and combined rejections compared to cellular rejection. And again, very difficult to differentiate that between no rejection at all. We then moved to utilizing another cell-free DNA, Prospera. And again, with utilization of a greater number of SNPs, the expectation that we could increase the sensitivity. Seeing again the data in front on the right side of the screen, acute rejection, borderline rejection, all the way on the right, stable patients, and OI as other injuries. And you can again see that, again, utilizing that 1% fraction of deceased donor cell-free DNA, that there was a discrimination between those biopsy specimens that were positive for acute rejection and those that were not. And so when we looked at this data in comparison, we began to see that both of these opportunities in utilizing deceased donor cell-free DNA were again a valuable adjunct to the use of monitoring patients' creatinine post-transplant. And again, the interest continued. The question was, if we were to put sort of both of these together, would we be able to recognize one potentially being more valuable than the other? So that study was done. So Dr. Melanson from George Washington, comparing, again, both AlloSure and Prospera, 76 patients that he matched biopsies with blood samples utilized both under the Natera platform and the CareDx platform. You can see the results on this, this particular slide. The sensitivity, 0.45 for AlloSure, 0.54 for Prospera, the specificity 0.84 and 0.69 respectively. And then the receiver operating curve, 0.73 and 0.74. So again, there was I think the reaffirmation that really both of these tests were valuable adjuncts to the post-transplant monitoring of our patients, but there was unfortunately still a low negative and positive predictive value, mostly for cellular mediated rejection utilizing both assays. And so the appreciation was, yes, we should continue to investigate this, but there is possibility for us to do better. In fact, interestingly, the conclusion made on the slide was that there was evidence that this remains key, but there still is potentially more to learn. And possibly the best thing to take away from this is that in order to maintain the organization within a transplant program, that a single platform is important. Then the question was, well, if we take away the percentage of cell-free DNA and look at absolute quantity, would we be gathering additional information? And that was done by the team at Natera. And you can see that on the x-axis, this is the percent of cell-free DNA that we've been talking about. And on the left, the absolute quantification of deceased donor cell-free DNA. And with that additional piece, the combination of tests increased the sensitivity, really increased it to 100% because 2 additional instances of T-cell mediated rejection were identified. And the specificity was increased to 87.5%. And so again, those that are utilizing the Prospera platform, you will get both of these results, and the combination of which is thought to, again, to increase the sensitivity and specificity of identifying rejection in our post-transplant recipients. Some summary of meta-analysis. 2 recent publications of 7 and 9 studies reaffirms with all of the data combined that there's a higher incidence of deceased donor cell-free DNA in those with antibody-mediated rejection, but did not truly differentiate very well T-cell mediated rejection and those without rejection. So the conclusions of those trials was that it can be a helpful marker in the diagnosis of antibody-mediated rejection, but probably not terrific for cellular mediated rejection. So moving forward, how about the utilization of gene expression profile? So the team from Northwestern, lead author John Friedewald, looking at banked samples from the CTOT trial, where they were again utilizing and developing of the whole genome expression of their recipients within that trial, looking at a combined outcome, which is on the left groups of bars. The 3 individual measures which made up that combined outcome really were defined mostly by the incidence of biopsy-proven acute rejection. This total gene profile, they were able to identify 57 really important called classifier genes that were some upregulated, some downregulated to help identify rejection. And you can see that the group on the yellow, which still getting used to the nomenclature of transplant excellence and no transplant excellence, there really was a distinguisher between those that had those changes in the gene expression profiling and the identification of biopsy-proven acute rejection versus those that did not. And so the value was seen as to be additive, the negative predictive value, positive predictive value at the top of the slide, still imperfect, And the question is, was this something which was going to, again, in addition to cell-free DNA, would the two of them together be additive? And that was this data that was presented just last year. The combination of utilizing now both AlloSure and AlloMap CareDx products. You can see when both of those tests were added, skipping over to the right, the pane B there, you can see that the combination of the two of them yielded an area under the curve which was much better than either of those two tests combined. And so there began to become a narrative that said the combination of utilizing both cell-free DNA and gene expression profiling would help us, identify the totality of potential rejection, and began to, I think, start to sort of pull out that one was perhaps better than for antibody-mediated rejection and the other potentially better for cellular-mediated rejection. And when you see that now, the combination of both of these tests, this again is the data out of Northwestern, the CTOT trial, utilizing gene expression profile and donor-derived cell-free DNA, and the combined test, you can see that when these two were added together, the positive and negative predictive value has increased significantly, 81% and 88% respectively. And the two pictures to the right began to, I think, really get us to where we are today. The gene expression profiling is really better at identifying cellular rejection, and donor-derived cell-free DNA is probably better at identifying antibody-mediated rejection. And so when we put those together, the combination, I think allows us to say that they are complementary and again, a valuable adjunct. And so sort of putting this together, I think it's important. I think the conclusions are that biomarker testing is useful, but there are still some performance gaps that exist. In terms of their positive attributes, there is a negative predictive value, which is at least 80% of all these tests. Deceased donor cell-free DNA is elevated in allograft injury, not just rejection, but in other things that may potentially injure our organ. It is less invasive than biopsy. Gene expression tests are probably best in identifying incidents of T-cell mediated rejection, whereas deceased donor cell-free DNA is probably best identifying antibody-mediated rejections. The current data is published, is only validated for adults and those with primary kidney transplants. But what we're here to say, and I think what we hope to be able to advance upon, is that there still is some opportunities to improve. The positive predictive value is, I think, still does not meet our needs. There is not an ability to utilize these tests to really identify severity of illness. So the ability to be able to determine how much treatment is necessary. It is less invasive. Certainly, it still requires a blood draw. The two tests together are valuable, but probably no single test is in and of itself going to give us all our information looking at both T-cell and antibody-mediated rejections. And we still need more information around multi-organ transplants, pregnant recipients, HLA identical, and pediatric recipients. And so I think that sort of sets the stage of where we are with biomarkers. And I'm going to hand things over to Alex Wiseman, who's going to introduce the next portion of our talk this morning.
Well, I really appreciate being able to participate in this symposium sponsored by NephroSant, and I especially am pleased to be able to work with two of my colleagues, both Dr. Samaniego and Dr. Cooper. And so I'm going to follow on from Dr. Cooper's presentation. He presented a lot of information regarding the state of affairs in terms of biomarker assessments in kidney transplant. It's remarkable that it's been 5 years and we have a lot of new tools that we've been able to use. And I think there's a lot of enthusiasm about being able to use new tools in kidney transplantation monitoring. I think, unfortunately, with that enthusiasm comes a lot of disappointment. I think all of us that have been trying these tools out and having gained experience with biomarkers realize that there's definitely some deficiencies that we're still struggling with. And I think they really focus around the issues of positive predictive value, timing of testing, knowing the conditions of use of testing. And I think that it's pretty clear that, based upon some of the conversations that Dr. Cooper was leading into, that is it going to be just one test that fits all, or is it going to be a multiple number of tests, or is the test that we're requesting or the characteristics that we're looking for within a test, can it provide more than one piece of information? And so this is what I'll be addressing in my component of the talk today is actually a novel tool for us to be looking at the kidney health assessment via QSant and the Q-score. So I do have disclosures that I'd like to share with you. I'm a part of a data monitoring board for both Meteor and Hansa, consulting for Veloxis, CareDx, Natera, NephroSant, and I'm on speakers bureaus for Veloxis, Sanofi, and CareDx. So the concept of having a biomarker that could fulfill multiple roles or multiple injury patterns is perhaps best exemplified by the possibility of using the QSant test, which does involve a number of multi-analytes for the study of kidney injury. QSant is really made up of 6 biomarkers that have been combined into a urinary test. And so these biomarkers, I'll just briefly give you a tour of the nephron that shows these biomarkers. First is marker number 1 is protein, which is indicative of podocyte injury. Marker 2 is tubular injury, indicative of clusterin. Marker 3, immune or inflammatory injury, exemplified by CXCL10. Markers 4 and 5 are both cell-free DNA markers for both apoptosis as well as enhancing the detection of parenchymal injury with methylated cell-free DNA. And then finally, the 6th marker, you can see at the bottom of the screen, is a normalizing control using urine creatinine, essentially controlling for diurnal variations in hydration status. So really we have within one test an ability to look for inflammation, apoptosis, tubular injury, and glomerular injury. And we hope that this can then lead to a much more robust test that can lead to better detection and better monitoring of our patients. So how is this test interpreted and provided to clinicians? So QSant is actually a urine biomarker that is essentially sampled from the ultrafiltrative urine. And again, you can see the 6 biomarkers that are listed 1 through 6 in the middle of the screen. And essentially taking these 6 biomarkers using machine learning and an artificial intelligence algorithm, a Q-score is calculated for each sample. And this algorithm is actually represented on a 1 to 100 scale. And using this scale, you can then apply this assessment to various clinical scenarios. We've had the opportunity to be able to see the results of this test in a number of clinical studies using stored samples of urine that have been connected to or drawn concurrent with biopsies. And I just want to review the primary paper that has essentially allowed us to understand a little bit more about the Q-score. So this was published in the Science Translational Medicine, and you can see the title is a urine score for non-invasive, accurate diagnosis and prediction of kidney transplant rejection. So what does this mean? So basically, 601 samples that were paired to biopsy samples had been analyzed using the Q-score technology. So, and again, these 6 biomarkers are cell-free DNA, methylated cell-free DNA, total protein, creatinine, clusterin, and CXCL10. Of the 601 samples, there were 364 that were from transplant recipients specifically. And of this 364 transplant recipients specifically, 332 were in adults and 80 were in pediatrics, which again gets to the point of trying to expand the knowledge base of biomarker assessments, not only looking at the adult population, but also the pediatric population. These 364 transplant samples are reflected over here on the right-hand side, looking at patient cohorts. So first, there's a training set of 111 samples with 39 representing acute rejection samples on biopsy, with 72 with stable graft function and stable histology. And then a number of validation steps and predictive steps went into play. And I'll share a few of these, but not all of these within this presentation. So you can see that there's a first validation set of 103, followed by a second validation set of 59. There is an injury prediction set that included borderline acute rejection and BK virus nephropathy cohort as well. And then there was actually a predictive data set looking at tests significantly timed before a biopsy demonstrating either rejection or stability. We won't talk about the healthy controls or the chronic kidney disease cohorts within this presentation. I'd really like to focus upon the primary findings, which are represented here. This is the first validation set once there has been interpretation of the exploratory data sets. And what you can see here on the far left is the Q scores in patients who had stable function by biopsy versus acute rejection. And these scores were substantially different, and you can see the mean scores were 13 versus 45. And this allowed for an assessment prior to this validation set of defining a Q score of 32 as a plus minus feature of inflammation versus quiescence, or a risk of rejection versus quiescence. And you can see, using this Q score of 32 cut point, the sensitivity and specificity of a score of 32 and greater, or greater than 32, is greater than 90% with an AUC of 0.98. Just looking at the pediatric population, you can also see that similar findings were demonstrated in those 80 pediatric samples. And again, this is from 10 months to 65 years old, from start to finish, both in the adults and the pediatrics. I think very importantly, and what has been missing in a number of other biomarker assessments, is the ability for a single test to predict both ABMR and T-cell mediated rejection. And so you can see that the Q score in both the settings of ABMR, or antibody mediated rejection, and T-cell mediated rejection are equally elevated and very similar when calculating a Q score for a given patient's clinical scenario in the setting of rejection. I think another scenario that is important to us is whether or not the Q score is as reflective of injury in a quiescent clinical state versus a for-cause state. So a surveillance biopsy series versus a for-cause biopsy series. And in fact, the Q score is equally represented for the detection of risk of rejection in the for-cause setting, as well as in a protocol or clinically quiescent setting. What I think is really exciting, actually, is the fact that instead of just viewing the Q score as a cut point and looking at that score as a plus minus feature with sensitivity and specificity, there may be more nuances than we can appreciate by looking at the score itself over the degrees of inflammation. So you can actually see that the Q score reflects the degree of injury, not just injury, yes, no. So it correlates quite nicely with BANF scores. As you can see on the left-hand side, the BANF acute rejection 1A, 1B, 2A, 2B actually trended upward in a consistent fashion with Q scoring. And then when you look to the right, you can see that the I score and the T score, the subsets of BANF scoring, also trended by the Q score. So an I score 1 through 3 was essentially reflected by a Q score that was elevated consistently, with a mean from 40 going up to near 80. Similarly with the T score of 1, 2, and 3, again showing adequate reflection in the Q score in a graded fashion. So it's not just a plus minus score, it does seem to reflect a degree of injury with an injury pattern that exists above a score of 32. This slide essentially reiterates the point that I just made, which is that there are scores that are reflective of the degree of injury that's not just applied to acute rejection. So as you look at the Q score in stable patients versus those with rejection on biopsy versus those that have borderline acute rejection versus another injury pattern such as BK virus nephropathy, you can see the Q score again reflects a degree of inflammation such that borderline is segregated from acute rejection, and BK nephropathy, which I think is still going to be a work in progress in terms of studying how its inflammatory score is measured in all of our biomarker assays, is not necessarily reflected by acute rejection or borderline acute rejection similarities. And again, you can see the sensitivity and specificity of the Q score in these settings in the setting of inflammation such as borderline and BK virus nephropathy. We've had another study that has been able to validate this landmark trial. And this publication in the Journal of Clinical Medicine essentially pooled data from 3 centers. Again, these are stored urine samples and correlated with biopsy findings. The patient cohorts, you can see in the middle column, there were 223 renal transplant samples that first were applied in a training set, looking again at that Q score for acute rejection versus stable grafts, and then a validation set. And again, you can see the significant disparity or separation in the Q score from those that are stable versus those that are diagnosed with biopsy-proven acute rejection, as you can see in label E, and sensitivity and specificity represented in F. I think this is a really exciting time for biomarker analysis and biomarker development. And again, just like I said, we've now been 5 years into this from a clinical utilization standpoint. We've been exposed to and have been participating in registry analyses or registry studies for biomarkers. And I just want to make sure that, what can we do to make a registry more robust and more useful? Would be to definitely combine what the registry is able to provide with site-matched retrospective cases that have not undergone testing. And this is exactly what the Aqua registry is planning to proceed with. And perhaps many of your centers have already learned about the Aqua registry. Essentially, the goal of the registry will be to enroll 2,000 participants with QSant testing and essentially match those in a site-matched retrospective manner with cases that have not been QSant tested. There will be comparison metrics that will be applied, such as assessment of number of biopsies performed, number of acute rejection events, any medication changes and hospitalizations. And I think that this will provide a lot more context and information in terms of future registry analysis and inform future decision-making. To summarize, I think all solitary biomarker tests do have good negative predictive value, as Dr. Cooper had nicely reviewed. And I think, unfortunately, many of us have felt this same issue, which is that performance gaps do exist across all rejection types, and we do require an improvement. Based upon the information that I've shared with you today, I think you could see that QSant does have the potential to improve the positive predictive value in the evaluation for the risk of rejection. And I think, interestingly, it may provide better quantification of that alloimmune injury, the degrees of injury that may exist within a given score. I think that the possibility that with a multi-analyte assessment, you might actually be able to tease out mechanistically what type of injury pattern applies or is driving a given Q score. And I think that this is a hypothesis that's in need of testing. And I think that with the Aqua registry and with other investigator-initiated proposals, perhaps what we will be gathering and be able to learn more about is being able to use biomarker testing such as QSant for assessment of adequacy of immunosuppression, indications for biopsy, and response to therapy following rejection. I'd like to now turn over the remainder of the didactic portion of the talk to my colleague, Dr. Millie Samaniego, to discuss real-world applications of QSant testing. And following this, I look forward to seeing you in a live Q&A chat at the end of this presentation.
In this section of the symposium, I will be discussing with you the clinical applications of QSant and re-emphasizing some concepts that we will keep in mind every time we select a specific biomarker for the monitoring and diagnosis of our patients. These are my disclosures. As you can see, I participate as consultant and investigator in several companies that manufactured and have developed biomarkers, and also in a pharmaceutical company. We need to consider in mind when we are choosing a biomarker, what we are trying to accomplish with it. Biomarkers should be considered as diagnostic surrogates. And usually the surrogacy applies to the gold standard, which in this case is the kidney transplant biopsy, that, as we know, have several deficiencies in terms of catching very early injury. At the same time, has problems with overlapping conditions or histology that could look very similar to each other, but that have a different genotype and a different etiology. Therefore, a biomarker should be one that is readily available, that has a high positive and a high negative predictive value, that allows the diagnosis of early disease when the disease is more amenable of response to therapy, should also allow us to evaluate the response of our patient to whatever therapy we had chosen, and allow us to differentiate between processes that can be presented in a very similar clinical phenotype, but that are pathogenically different. So what is the advantage of utilizing QSant in monitoring your patients? With QSant, you move from the late diagnosis of rejection, clinical diagnosis by elevation of the serum creatinine, the eGFR, or whatever marker of function you are utilizing, to a diagnosis of molecular immune injury of the transplant and evaluation of the risk that actually an acute allogeneic event is occurring. The difference between molecular, histological, and clinical is that one would expect that when a diagnosis is made at a molecular level, this will be the time in which the likelihood of response to therapy will be the best, and treatment, therefore, will have better efficacy and lead towards a better outcome and function of the allograft, compared to one we have to start treatment based on histology or clinical parameters. So keeping in mind 0 to 32 is a range in QSant that indicates stability in histology and stability in the transcriptomic or the molecular genomic pattern of the tissue. Every time we had patients in this range, we would continue to do normal monitoring of the patient and maintenance of the therapy we have chosen. Once we encounter patients that have a range be above 32 and 55, we recommend the retesting of these patients. If in 2 weeks the QSant has decreased to less than 32, clearly we can continue to do the normal monitoring. If it is above 55, then definitely make a decision of whether or not we should proceed with the biopsy, or if we are comfortable enough and have developed experience with the use of the Q-score and QSant, then proceed with treatment and continues to monitor, evaluating not only the recovery of the stability of the allograft, but also the response to treatment. Therefore, you can see that this allows you in the decision-making of what to do with your patient. It not only helps you to make a very early diagnosis, but at the same time to decide if intervention is necessary. And we are all aware of the difficulties that we encounter in order first to convince the patients to have a biopsy that is not indicated, as is the case, of the protocol or surveillance biopsies. In this case, we can monitor our patients using QSant and perhaps avoid an unnecessary biopsy. At the same time, it is many times we encounter non-allogenic injury that is reversible over a short period of time, and we still biopsy the patients, and we don't change management because we don't find any specific indication for this. These patients will then be included in this, and clearly once your range is above 55 to 100, then it's whatever you think is appropriate, either treatment or a confirmatory biopsy, what it should be recommended. So compared to the biomarkers that are in the market, QSant is a urinary biomarker, as you have already heard. In the slides that Alex showed, we have selected specific proteins that are detected with the Q-score that can pinpoint different specific areas of the nephron. Urine is actually a very stable fluid and can be remain stable and have diagnostic accuracy even 2 weeks after the urine sample has been obtained if maintained at adequate temperatures. In this way, whatever proteins are being generated and detected in this urine sample then will be identified and processed through artificial intelligence to then generate the Q-score that you are dealing with. The early access program was a group of patients that was initially studied, approximately 235 patients, that with kidney function and diagnosis range from stable to subclinical rejection to acute rejection. And the time post-transplant was as short as 6 days and as late as 27 years after transplant. 21% of the patients initially included in the early access program were promoted to serial monitoring. And what we found here was that all these patients, based on the Q-score, 38% of these patients were stable. Close to 50% had presumed subclinical acute rejection, and 12.3% have clinical acute rejection. We can see then fairly easily how the Q-score can help us to identify a stable or a quiescent organ versus subclinical rejection. That will be the earliest moment in which we would like to intervene in the history of the allograft injury. It's also very useful in the diagnosis of acute rejection, but as we discussed, it is always better to initiate treatment at the time of the earlier intervention. What we see here are the different monitoring patterns. Each column represents a different patient. And we can see that patients that had a score below 32 were clinically stable and no change in immunosuppression was pursued. That patients that have either antibody or T-cell mediated acute rejection are way above the 32 margin and can be identified in between the 32 and 55. This will be the level of early and subclinical rejection, Whereas when the biopsy was performed based on QSant numbers, we can see that every patient that had a QSant range of 55 to 100 all had biopsies that were confirmed from the histological standpoint. Now, how can this be used in the different clinical scenarios that you encounter in the clinic? We are going to present here 4 patients with different type of conditions. One is a patient that presents with subclinical rejection, another patient with persistent rejection, a case in which the biopsy was avoided with the use of the QSant and the Q-score, and a condition in which the patient avoided a biopsy because the QSant indicated that the kidney transplant was stable. In the first case is a patient that undergoes surveillance biopsy. Markers of function are within completely normal parameters, so no one will expect any evidence of injury in the allograft. However, when the biopsy is performed, the histological diagnosis is one of chronic active T-cell mediated rejection 1A. At the time that this biopsy is done, the Q-score in this patient is 66. So it's exactly in the range in which we will expect subclinical rejection to occur, which using the Q-score will be between above 32 and 55. Now, the patient is treated with oral steroids, and we continue the follow-up of the patient to reevaluate not only the response to therapy, but also the improvement in the allogeneic injury of the transplant. Kidney function remains within normal limits. And what we see is that the Q-score diminishes from 66 to 41 and 38, but never returns to the Q-score that one would consider to be a stable or a marker of stability that will be from 0 to 32. Follow-up biopsies confirm that this patient continues to have injury in the allograft, allogeneic in nature, and shows progression of disease as well from a T-cell mediated rejection 1A, chronic active, to chronic active T-cell mediated rejection 1B. So we can see here how well we can assess the evolution of the histology and respond to therapy in these patients. Whether you can decide at this point to do another intervention is feasible, and what we would do would be to continue to monitor the patient with the hope that with different treatment, the Q-score will come to a stable stage of 32 or lower. In a patient with persistent rejection, you see this is a patient 8 years post-transplant. The patient is diagnosed by biopsy with T-cell mediated rejection, BANF2B, and chronic active antibody mediated rejection that occurs also during a period of acute COVID infection. And at this time, the serum creatinine is 2.3. The Q-score in this patient was 45. Patient is treated with pulse steroids and oral steroids. One month after treatment, the Q-score remains essentially unchanged, and 5 months later actually has increased further, indicating that not only the allogeneic injury is still present, but is actually worsening. This might be as well the time that we may choose to offer an investigational therapy to this patient or to try to use other alternative treatments that may be available in the armamentarium. In this case, this is a patient 2 years after transplant in which the serum creatinine is 1.44, a little bit, that's the baseline, GFR 4577 milliliters per minute, and the Q-score in this patient is 23. 4 months after follow-up, the patient presents with elevation of serum creatinine to 1.51. At that time, we test the urine, obtain a Q-score of 13, and we know that this is in the molecular and histological stability range. Even when the eGFR decreases further and the serum creatinine is above 1.8, the Q-score stays in the area of stability. Most likely, this is a patient that has calcineurin inhibitor toxicity, which actually is a common finding in many of the protocol, but also clinically indicated biopsies. In this case, the follow-up in time of the Q-score allow us to avoid a biopsy. And finally, there is a concern of a patient about the possibility of rejection. This is a patient that presents with an elevation in serum creatinine and at the same time, a Q-score that is performed is 27, again, within the range of stability. The patient is further studied, and we find in an imaging study that there is renal artery stenosis of the transplant, which is corrected by the placement of a renal artery stent after PTA. And 1 month later, the creatinine unfortunately goes up to 3.14, but again, the Q-score is 22. In this type of patients, most likely is ongoing ischemic injury that may be the result of ongoing microvascular disease or other type of injury, but not the result of rejection. So we will stop here and we'll address your questions and comments, and we will be providing the best possible answers to your inquiries. Thank you very much.
Okay, well, welcome to the audience, and I appreciate the opportunity to be able to share the screen with my co-moderator or co-speakers today. I also want to, so reintroductions, Dr. Matt Cooper, Dr. Millie Samaniego, and I do want to introduce Dr. Minnie Sarwal, who's a professor in residence in transplant surgery at UCSF and the founder of NephroSant. So we, as probably most of you are well aware, she spent her scientific career in studying predictive markers for allograft kidney health, and she can give a lot of the historical and developmental aspects of QSant and Q-score as questions come in. So thanks, Dr. Sarwal, for making yourself available for today's question and answer, because perhaps there will be some details about how things came to light. We do have a few questions that have come in, and I really appreciate the audience's participation so far. One question really focused upon what to do with a positive test. And so when we say positive test, as Dr. Samaniego described, this test could be considered to be greater than 32, greater than 55 for clinically significant or highly likely findings for allograft injury rejection. So the question is, so if treatment is brought up as an endpoint for finding out a result, so you have a result, and now treatment is proposed, is it still necessary for us to be recommending biopsies to interpret and to determine the type of rejection? I think the question really gets at the point of, are we at a point with QSant or with any other study or any other biomarker where we can make a decision based upon a positive result rather than go to a confirmatory biopsy? Would you like to take this, Dr. Cooper?
Yeah, I was hoping you'd give me the first shot at this one, Alex. So it's interesting, if you're fortunate to have been in the business for a while, now 20 years, in fact, a lot of what I learned is from Dr. Samaniego from way back in Johns Hopkins. We put so much emphasis on the value of the biopsy because we realized the insensitive nature of measuring serum creatinines. Terrific. And then we did all our own biopsies as a transplant fellow, and you became very comfortable doing those, and the information you got was invaluable, particularly when you had renal pathologists who were outstanding at looking at lots of kidneys. You then sort of progress over the course of the next sort of 10 to 15 years. And, as a physician who doesn't like sitting on their hands very much, you see creatinine and you have your examples of folks, even in the face of normal creatinine, that utilizing a protocol biopsy fashion, you identify these early rejections and you think, boy, I used to believe that potentially there was a high risk and a low risk population, and you could sort of sleep well at night thinking I identified who I needed to keep closer watch on and who I didn't. Over time, you start to see that group of high risk gets larger and larger, particularly when you talk about, as I mentioned in my talk, non-compliance, that you start using protocol biopsies. And then you have a lot of data, and you have a lot of potential complications. And as I said as well, complications that bring you back to an operating room and potentially lose a graft. I think biomarkers are incredibly exciting, and I'm not here to say that there's a desire to say, do we have a winner here? Is one better than the other? I think they are additional pieces that we can use in the armamentarium of caring for these complicated patients. But I'm not personally ready to give up the biopsy. I think they give me more information as to when a biopsy is necessary, so that I'm not relying on protocol biopsies, and so that I'm not, we'll get maybe to this as well, particularly after treatment, I'm not sort of hoping, did I do well enough? And then wanting to say, maybe I need to get another biopsy, because that was always the other piece of, if I believe in the biopsy to determine treatment, then in theory, I still need to believe in a biopsy after the treatment to say that I do enough. And so I don't think I'm ready to give up biopsy yet, and I'm happy we seem to have gotten further and further away of calling this a liquid biopsy. But I think this is a complementary piece to make me a smarter consumer, as it were, of when a biopsy is necessary.
Really appreciate that insight. I think that as a follow-on question, and this probably is best answered by Dr. Samaniego, the question is posed: what do you think how do you think a clinician should use the Q-score? What's the best scenario, to look for graft stability or to look for graft injury? So you want to give it a go there, Dr. Samaniego?
Yes, I'd be happy to answer that question from Dr. Kumar here. I actually think you can use it for both, but you need to learn how to utilize the biomarker. And using the technique is going to teach you in your patients how the test behave in your population. For example, you get a protocol, and this test should be ordered following a protocol as the one recommended for QSant. And if you see stability in the patient, you are happy to continue, but you know where your patient is stable. Therefore, any variability in that level of stability should suggest that there may be, or could suggest that there is something ongoing in the allograft. Usually in the beginning, when I use this type of test, I tend to evaluate the patient with a biopsy to try to see the correlation taking into consideration all the deficiencies of biopsies. But if there is a correlation on a specific variation and what I see in the biopsy, I start acquiring more experience. And I feel, I said I developed the knowledge, the practical knowledge to how to interpret the result. So in summary, you can use it for both. If it is stable, then your patient is stable. If there is a variability, I would like usually to wait, repeat, and if the variability continues, then investigate further.
Thank you. I think Dr. Anand has an interesting question, one that I also have and that I am very interested in. So Dr. Anand proposes on a report. So we get back a Q score, of course, and then we make determinations based upon a score. He asks, on the report, is it possible to have the scores on individual components and hence guiding the clinician toward type of injury pattern with an intent for the clinician to intervene accordingly? So this, I think, is perhaps one of the, I brought this up as a hypothesis that needed to be tested, and I do think the technology could exist. I think that first and foremost, in my view, and I'm going to actually I'm going to ask Dr. Sarwal to comment because this is going to get into a little bit of the technology aspects of the test. But from my perspective, I think that if you have we're in the state of QSant 101, where we're learning what the score itself means. And I think it's really important to learn what that score itself means. But I think as we gain more and more and more knowledge in the clinical scenarios that we're all very interested in, whether it's in the, in inflammatory AKI versus non-inflammatory AKI, or autoimmune versus alloimmune, and different components may play different roles, or infection-related AKI. We may have different signals within the different components of a urinary multi-analyte test. And so I think that, to me, would be QSant 201. We're at QSant 101, where we need to learn the test specificity and sensitivities in real-world practice. And I think that the registry is going to be very, very important for us to do so, but that'll be the next level. I will turn this over now to Dr. Sarwal to comment about technology and feasibility of that question. Hopefully we have her in a place where she can communicate.
Yeah, can you hear me?
Yes, great.
Can you hear me? Yes.
Yes.
Okay, great. Yeah, thank you for that. I think it is exciting to actually have a set of 6 markers that actually look at different compartments of the kidney and their impact during rejection. And I think one of the things that we will be examining through the conduct of the AQUA study is to then evaluate during rejection episodes what the interplay of these different markers is at the time of rejection. Because one thing to clarify, not all acute rejections are high in cell-free DNA. And that basically feeds to the lack of the high accuracy that one would want to get from just looking at a single marker in blood. And a single marker in urine would also not suffice. So what we are trying to understand is what is the heterogeneity of the injury and rejection. And we know that rejection is different based upon, tissue microarray analyses and other studies that have been done by other groups. We also know that the temporal nature of rejection is such that you may be capturing it early or late. You could be having a partially treated rejection episode where you see tubulitis, but the cells may not be as active. So what we're hoping is through this is to start to understand that heterogeneity of injury through the breakdown of these different markers, and then start to understand when treatments are given, could they be chosen differently based upon the behavior of these markers at the time of rejection. So I think this is definitely an exciting space for us that we're working on, and something to look at, and something that we should be able to answer better after the close of the AQUA study.
Excellent. So I have another question. This question, of course, is going to be a challenging one. It's from Dr. Ken Newell, never short on answering challenging questions. He basically asks multi-part questions, so listen carefully. Do each of you use a biomarker as part of a standard pathway in your clinical practice? If so, do you use one or a panel? And given the costs associated with testing, does this impact your center or patients financially? So multi-part question. Do you have a biomarker pathway testing at your center? Do you use one or a panel? And are you considering the cost to the center and to the patient? Dr. Cooper, would you like to?
Yeah, sure. Thanks, Alex, and thanks, Ken, for asking the question, because that's really where the kind of the rubber meets the road here is what's the applicability of these tests, particularly since, as I said in my presentation, it's been since 2017 that we started having an interest in this. So I'll say at our center, we utilized biomarkers, but not in a protocol fashion, perhaps as much as I would like to. The challenge is, and there certainly are some practical challenges as well. You're talking about adding an additional test to an already complicated process of caring for comorbid patients. And so, ensuring that you have the tests connected to your EMR is a piece of this. Let's not forget the fact that we are, asking our post-transplant team to sometimes monitor, several hundred transplant patients a year. So I'll say we're still in the process of figuring out how it is best integrated into our program, and we're right now utilizing it on a for-cause practice and not necessarily in a protocolized fashion, although we're moving closer and closer to that. We do believe that it has significant value, and in fact, to my example earlier, we've identified some patients who were sort of fit into the category of low risk that as part of these registries with which we're participating, and I encourage everyone to participate because you get an experience like none other. We've identified some early rejection in patients that we would not have predicted that under biopsy concurred the fact that we had something that necessitated intervention. And so we're still sort of getting our place where we're getting experience with all of these biomarkers and then trying to work to figure out how they fit into our clinical practice. Are they right for all patients? And is there potentially a combination, or as Ken asked, a panel of tests which we think act complementary to one another? So we're getting there. We're not quite there yet, but again, I think it's important for folks to get an experience with these if you haven't before, because they do have a significant clinical benefit to the care of these patients.
Dr. Samaniego, would you like to comment on your experiences?
Yeah, briefly, we use different biomarkers. And as we develop experience in the beginning, we tend to investigate further any changes in the biomarkers with indication biopsies. Henry Ford is not a protocol biopsy program. We do 1 year protocol biopsies, but the majority of our biopsies are for indication. So in the case that the biomarker is abnormal, the patient undergoes a testing of DSA, BK, viremia, and a biopsy. Until recently, we were only looking at the histology. More recently, some of the cores, depending on the physician's preference, have been sent for MMDX to Thermo Fisher. In summary, I think the combination of biomarkers is where the money is going to be. There are advantages and disadvantages on all these markers. I think that having a marker that looks at tissue, at urine, and at the same time, or in combination with a marker that looks at blood transcriptomic, is probably at the end going to be the best combination in patient management.
Okay. I'll give my little editorial as well, just about our experiences. So I have been an early adopter in terms of utilization of biomarkers, and I think that utilizing biomarkers to understand the technologies that are given to transplant centers and transplant patients is very important. I think cost considerations globally are something that needs to be considered as data are collected, and I think we need to reassess as we move forward, studying each new biomarker, each new combination of biomarkers in the context of what question we want to answer in the clinical circumstance that we're applying. So similar to Dr. Samaniego, we apply multiple biomarker assays that donor-derived cell-free DNA, as well as BK monitoring, as well as DSA screening, and we've implemented QSant testing in patients who have had an event that we want to track further on. Mostly because I think it's very important for us to learn as representatives of the transplant community, and really be able to provide guidance not only to the people that are creating technology for us, but also to the patients and to the payers. So I do think that all of those things are critically important as we move forward. I think registry analysis is, again, the first step. Reassessment of what the registry is telling us and reassessment of what the value of registries are is very important. I'm encouraged by the utilization of control arms in registry analyses that are proposed by, for example, the Aqua study as something that will be value added in the future. So I think we have a couple other questions, and these deal primarily with the data and interpretation of the data a little bit. So we'll get slightly into the weeds of the clinical studies. So one question is, when patients are in the gray zone, as it was referred to in this question, between 32 and 55, what is the rationale for 2-week interval testing? And I know, Dr. Samaniego, you had that proposal on your slide, and the terminology of using the word gray zone, I think one could say is either early inflammation or subclinical inflammation or some other terminology. Would you call that a gray zone, or would you act upon that 32 to 55 in any different manner? And why the 2 weeks, I guess?
I think that the whatever phenomenon that is ongoing in the transplant is sort of a fluid kind of event. If I am not in the clear zone of quiescence or the highest level where I know the test is positive, I prefer to wait and investigate further. And if it is a trend, definitely then consider to do further testing. But very often what you would see is that at that point in time, the test can come back to the quiescent state, or that's what the QSant indicates, that the allograft returns to the quiescent state. Now, why 2 weeks as opposed to 1 or 3 days? Well, that it was it's sort of an arbitrary period of time that was established during the studies that NephroSant was conducting, and I think Minnie can explain a little bit more about why specifically 2 weeks as opposed to 5 days or 1 month. I don't know, Minnie, are you on the line?
Yes, I am.
So I will. So, Dr. Saul, I'll be happy to have you answer this question, but I just want to be cognizant of the audience. We have just a little over a minute left, so if we can have a punchline to that answer, that'd be great. Yeah.
Yeah, it's not arbitrary. It's just basically, it was just a recommendation. It can be done the next day. It can be done 5 days later. It was just an approximate timing.
Yeah, and I suspect that this is along the same lines of, we need to gather information of how the test functions in evolution of an injury pattern, and so it probably reflects clinically relevant timing. So perhaps we don't want to let injury patterns go more than 2 weeks before reassessment. I would
it's similar to how we approach DSA too. I mean, that's how we've learned. So I think it's a learning process.
Yeah.
Yep.
Agree.
So I think that with that, we can wrap up this session. I really appreciate the audience's participation. We had a great number of questions, and unfortunately we didn't get to a few of the questions in the appropriate time that we were allotted. But I would like to, again, thank my co-speakers, as well as Dr. Sarwal for joining this panel discussion. I hope that this was educational as well as informative discussion that provokes a lot more conversation in the biomarker field. So thank you very much on behalf of my speakers. Appreciate it. Everyone take care and enjoy the rest of the meeting.
Thank you.
Thank you.